Welcome back guys. Now in this video let's discuss about macrocytic anemias. Macrocytic anemias. So what exactly are these macrocytic anemias? You already know it. So what is the normal volume of the RBCs? The normal volume of the RBCs is 80 to 100 femtoliters. If the mean corpuscular volume, if it is greater than 100 femtoliters, okay, if it's greater than 100 femtoliters, then it is called as macrocytic anemias. Now, what are the causes of the macrocytic anemias? Why macrocytic anemias? Let's write the causes here. The causes are, number one cause is vitamin B9 deficiency, vitamin B12 deficiency. Okay, B9 that's a folate deficiency, B12 that's cobalamin deficiencies. Next, it can be seen in persons who are alcoholics, and it can be seen in patients who are having liver disease. Okay, the persons who are using certain drugs like 5-fluorouracil, methotrexate, okay, which are folate antagonistic drugs. So these are the points which I want you to know. The causes. See, why vitamin B9 deficiency and vitamin B12 deficiency? See, these are the two most important things. Why vitamin B9 and B12 deficiency is going to cause the megaloblastic anemias? How? See, vitamin B9 and B12, the folate and cyanocobalamin are very important for the production of DNA precursors, important for synthesis of DNA precursors. Okay, so for the production of the DNA precursors, or simply we can say for the production of the DNA, you require the vitamin B9 and B12. If vitamin B9 and B12, if they are deficient, okay, if they are deficient, that causes improper DNA synthesis. The DNA synthesis is not happening, no DNA production. Without DNA production, do you think cell division is going to occur? The cell division is not occurring. So RBC production, continuous cell division is not occurring, sir. Okay, so the point which I want you to know is, see, actually you require cell divisions. Okay, you require cell divisions for the production of mature cells from the immature cells, which are called as the blastic cells, the immature cells. Hematopoiesis is happening, right? From the hematopoietic stem cell to the mature RBC. See, one thing which I want you to appreciate here is, so the immature cells are bigger cells and the mature cells are becoming smaller cells. The more the number of cell divisions, the cell size will gradually reduce. Okay, now here, because of the vitamin B9 and B12 deficiency, the DNA precursors are not synthesizing, no DNA replication. Without DNA replication, cell division is not happening properly. So the main problem here is the cell division. The cell division is not occurring properly. As the cell division is not occurring properly, you are going to left with the immature cells. Okay, what you are having mainly in the bone marrow and that's coming into the bloodstream is the immature cells are coming. Okay, it's the immature cells coming. So immature cells are definitely larger. Okay, the immature cells are definitely larger when compared to the normal. So that's why the name that's why the name macrocytic RBCs. Okay, macro means bigger. Macrocytic means bigger cells are there. Which bigger cells? The RBCs. See, not only this is true for the RBCs, but even true for the WBCs also. Okay, even true for the WBCs. Even the WBC size will increase, greatly increase. Okay, so if you look at the WBC, they are also not properly dividing. So you are going to have bigger WBC. What you will see is, for example, say this is the WBC. In a mature neutrophil, you will be having 3 to 5 lobes. Okay, 3 to 5 lobes of nucleus. But in an immature WBC, you are going to have multilobated nucleus, more than 5 lobes. Okay, more than 5 lobes is going to be seen. Such type of neutrophils are called as hypersegmented neutrophils. Okay, such neutrophils are called as hypersegmented neutrophils. Now, whenever you see such hypersegmented neutrophils, definitely it is macrocytic anemia. That too, see, if a macrocytic anemia, if it is due to vitamin B9 and B12 deficiency, if the macrocytic anemia, if it is due to vitamin B9 and B12 deficiency, that is called as megaloblastic anemia. Okay. Megaloblastic, in the name itself it says mega means bigger, blastic means immature cells, megaloblastic anemia. So hypersegmented neutrophils are seen in megaloblastic anemia, vitamin B9 B12 deficiency, immature cells, bigger cells. Okay, so this thing. Apart from this, what else I have to teach you is, say, how folate, how you will get the folate? You will get the folate like via green leafy vegetables or from some fruits, you will get it. So folate, once it enters into your body, it's going to be methylated. Okay, it's going to become methyl tetrahydrofolate. Okay, it's become methyl tetrahydrofolate. Say, if you want to send this folate to DNA production, or we should say, what kind of folate is required for the DNA production? It's normal tetrahydrofolate. Okay, tetrahydrofolate is required, not methyl. So this methylated group need to be donated. Who will accept this methylated group? This methyl group is accepted by the vitamin B12. So now methyl group is here. That's the CH3 group is there with the vitamin B12. Now this tetrahydrofolate is going for the DNA synthesis. Okay, DNA precursor synthesis. Now this vitamin B12, it is a methyl donor. It will also donate. To whom it will donate? It will donate it to homocysteine. The biochemistry, the homocysteine, by acting the, by receiving, by accepting this methyl group, okay, by accepting that methyl group, it will become methionine. Okay, methionine, sir. One important thing. And what I want you to know here is, sir, in B12 deficiency anemias and in folate deficiency anemia, see, this is vitamin B9, this is vitamin B12. So what changes are going to be appreciated, that I will explain you. Okay, within a minute I will explain you. See, now after this, let's start with the B9 deficiency. Okay, folate deficiency. So from where you will get the vitamin B9? You will get the vitamin B9 from fruits and vegetables. Fruits and vegetables. So if you are not taking proper diet, you will get vitamin B9 deficient. Or if you are using drugs like 5-fluorouracil, okay, 5-fluorouracil or methotrexate. See, these are folate antagonistic drugs. These are folate antagonists. Okay, so methotrexate used in the treatment of ectopic pregnancy, methotrexate used in the treatment of cancers, 5-fluorouracil used in the treatment of cancers. Using these drugs can also cause vitamin B9 deficiency, vitamin B9 deficiency. So what are the clinical laboratory findings will be seen? Okay, what are the clinical and laboratory findings? Okay, laboratory finding. The patient is having vitamin B9 deficiency. Yes, the patient is going to have megaloblastic anemia. Okay, macrocytic RBCs, megaloblastic anemia is seen, no doubt. Means in the lab, what you will see? Big RBCs, megaloblasts are going to be seen with the hypersegmented neutrophils. Okay, hypersegmented neutrophils can be seen more than 5 lobes. Apart from this, these things already you know it. Apart from this, what else? See, vitamin B9 is not there. Okay, vitamin B9 is not there. When vitamin B9 is not there, okay, so methyl group is not going to vitamin B12. When methyl group is not going to vitamin B12, the conversion of homocysteine to methionine is not going to happen. So which levels are going to be elevated in the blood? So the homocysteine levels are going to be elevated. That's the important question. Okay, homocysteine levels. So homocysteine levels are elevated. Okay, and methyl malanoic acid. Okay, methyl malanoic acid levels are maintained normal. Why I am talking about the methyl malanoic acid levels now here? Because see, in B12 deficiency, later on I am going to explain about the second type of megaloblastic anemia, that is B12 deficiency anemia. See, in B12 deficiency anemia, methyl malanoic acid levels are going to be elevated. Okay, so don't forget about it. Methyl malanoic acid levels are going to be elevated. Okay, in where? In B12 deficiency, not in folate deficiency. Okay, not in folate deficiency. Okay, so lab findings are going to be, yeah, of course, serum folate levels. Okay, serum folate levels are going to be reduced. Normal methylmalonic acid levels. Okay, so these patients are going to have what else clinical features? Because of this megaloblastic anemia. Okay, because of this megaloblastic anemia, The patient is going to have hypoxic symptoms, easy fatigability, okay, nausea, easy, getting tired very easily. The pale conjunctiva can be seen, these things, and glossitis can be seen. Okay, glossitis can be seen. Okay, atrophic glossitis. So these things are seen. Now let's talk about the B12 deficiency anemia. See, why someone can get B12 deficient? Okay, see, usually people won't get B12 deficient, very rare, because we have sufficient stores of B12 in the liver. Okay, in the liver there are sufficient stores of B12. Usually no one will get vitamin B12 deficiency until unless they are a pure vegans. Okay, not even vegetarian, pure vegans. They are not at all touching the animal product. Okay, now you can ask me why I am talking about the animal products now, because vitamin B12 is one vitamin, cyanocobalamin is a vitamin you will only get from animals. Okay, so those people who are completely avoiding the animal sources, at least they have to take milk, okay, milk, butter, ghee, kind of thing. Okay, so those people who are completely avoiding the animal products, they can get vitamin B12 deficient. Okay, they can get vitamin B12 deficient because vitamin B12 is a animal derived protein. So how vitamin B12 is absorbed? See, our salivary glands, okay, our salivary glands produces something called as R binder. Okay, protein called as R binder. See, now this R binder, okay, now this R binder is going to bind with, okay, R binder is going to bind with vitamin B12. Okay, vitamin B12. So this is called as vitamin B12 R binder complex. Now this vitamin B12 R binder complex, when it is coming into the duodenum, okay, it's coming into the duodenum. Now in the duodenum, whatever the proteases that are getting produced is going to cleave. Now it is going to cleave the vitamin B12 and R binder complex. Now vitamin B12 is free. Now this vitamin B12 is going to bind with intrinsic factor. Okay, intrinsic factor. So vitamin B12 in the duodenum, where it is binding with? It is binding with the intrinsic factor. Now you can get a question from who is producing this intrinsic factor. So this intrinsic factor is produced by parietal cells. Parietal cells. Now where are these parietal cells? The parietal cells are present in the stomach. So in the stomach, in the gastric mucosa, there are cells called as a parietal cells. Now those parietal cells, of course, they produce acid. Parietal cells produce acid as well as intrinsic factor. Now this intrinsic factor is going to bind with the vitamin B12. So this is called as B12 intrinsic factor complex. Now this B12 intrinsic factor complex is going to be absorbed in terminal ileum. Okay, so only vitamin B12 is absorbed. Only vitamin B12 is absorbed in the presence of intrinsic factor. Without intrinsic factor, vitamin B12 absorption is not going to happen. It's not going to happen. Okay, so this is something normal physiology. Now, why someone get vitamin B12 deficiency? Okay, one reason is if they are a pure vegan, completely avoiding the animal products, that can lead to vitamin B12 deficiency, or diseases like malabsorption syndromes. Okay, malabsorption syndromes. Anything like Crohn's, ulcerative colitis, or parasitic infections like Diphyllobothrium. Okay, Diphyllobothrium latum. See, this Diphyllobothrium latum is a fish tapeworm. Is the fish tapeworm. See, this Diphyllobothrium latum, where it will live? It lives in the terminal ileum. Okay, it lives in the terminal ileum. As it's living in the terminal ileum, it interferes with the absorption of the vitamin B12. It's causing ileitis, so inflammation. So during that inflammatory conditions, vitamin B12 absorption is not going to happen properly. So that can lead to vitamin B12 deficiency anemia. That's the one reason. Crohn's, ulcerative colitis, Diphyllobothrium latum infections are autoimmune conditions. Autoimmune condition. See, what is this autoimmune condition? There is autoimmune condition called as pernicious anemia. So what is this pernicious anemia? In this condition, sir, antibodies, okay, the antibodies are produced against parietal cells. Parietal cells. Now parietal cells are getting damaged. So when the parietal cells are getting damaged, sir, acid production goes down. Also the intrinsic factor levels goes down, intrinsic factor production goes down. Now my question to you, sir, if the intrinsic factor is not there, do you think vitamin B12 is going to be absorbed? So intrinsic factor is not there. So this patients having severe deficiency of intrinsic factor. Without intrinsic factor, that will cause B12 deficiency. Okay, intrinsic factor is not there, so B12 is not getting absorbed. So that's one of the cause of vitamin B12 deficiency. Okay, so Crohn's disease and ulcerative colitis, you know, they are inflammatory bowel diseases. So absorption of the substances will decrease. Diphyllobothrium latum infection, autoimmune conditions like pernicious anemia, and vegans can get deficient in the vitamin B12. Okay, now if a patient is having vitamin B12 deficiency, what are the labs that are going to be seen? What are the labs? So serum B12 levels are going to decrease. One thing. What about the homocysteine levels? See, vitamin B12 is not there. I have explained you, vitamin B12 if it is not there, no one is giving the methyl group to the homocysteine. Okay, no one is giving the methyl group to the homocysteine. So homocysteine is not getting converted into the methionine. So what happened to the homocysteine levels? The homocysteine levels are elevated. Okay, homocysteine levels are elevated. So even B12 deficiency, okay, even B12 deficiency, homocysteine levels are elevated. Okay, homocysteine levels are elevated, sir. Now here, in this condition, the methmalonic acid, okay, the methmalonic acid levels, these are also elevated, sir. But in folate deficiency, I have explained you, in folate deficiency, methmalonic acid levels are normal, but here it is elevated. Why? Because you need to convert the methmalonic acid into succinyl CoA. So, methmalonic acid biochemistry, sir, it's converted, it needs to be converted into succinyl coenzyme A. Methmalonyl CoA or the methmalonic acid it need to be converted into succinyl CoA. With the help of what? With the help of vitamin B12. Okay, with the help of vitamin B12, the methmalonic acid is converted into succinyl CoA. When vitamin B12 is not there, what happened to the methmalonic acid levels? Elevated. So that's why methmalonic acid levels are elevated. This elevated methmalonic acid, okay, this elevated methmalonic acid levels are going to cause damage to the spinal cord or the myelination of the spinal cord. Okay, so this methmalonic acid levels are going to cause a condition called as subacute combined degeneration. Subacute combined degeneration of spinal cord, where especially the myelination, mainly the myelination is getting damaged because of the accumulation of this methmalonic acid levels. Mainly the posterior column, we know it, right? The posterior column of the spinal cord, the posterior column of the spinal cord, the fine touch, vibration, proprioception information is going in the posterior column. The advanced sensations are going in the posterior column of the spinal cord. So the posterior column, as it's getting damaged, the patient is going to have loss of proprioceptive information. Okay, proprioceptive information and vibratory senses are affected, because you know the posterior column of the spinal cord is highly myelinated. Because of the accumulation of the methmalonic acid levels, the posterior column of the spinal cord is getting mainly affected. That causes a subacute combined degeneration of the spinal cord. So in B12 deficiency, okay, in B12 deficiency, the patient is having neurological symptoms. That's the MCQ. In B12 deficiency, the patient will experience neurological symptoms. But in B9 deficiency, folic acid deficiency, such kind of neurological symptoms are not seen. Okay, such kind of neurological symptoms are going to be absent. Okay, so what you will see here in B12 deficiency, also same thing, hypochromic, hypersegmented neutrophils can be seen. Okay, hypochromic RBCs can be seen. Even these patients will be having atrophic glossitis. Okay, atrophic glossitis can be seen in these patients also. Okay, having said that, we have discussed all the important points regarding the macrocytic anemias. That's both B12 deficiency and B9 deficiency, how they are going to cause the megaloblastic anemias, and how to differentiate between B9 deficiency and B12 deficiency. Again, I am telling you, to differentiate between B9 and B12, you have to check the methmalonic acid levels. B12 deficiency increases the methmalonic acid levels. In B9 deficiency, methmalonic acid levels are not elevated. Homocysteine levels are going to be elevated both in B9 deficiency as well as B12 deficiency. Neurological symptoms seen in B12 deficiency. If it is a megaloblastic anemia, hypersegmented neutrophils are seen. If you see that word hypersegmented neutrophils, it is macrocytic megaloblastic anemias. Okay, so with this macrocytic anemias are also completed. In the next video, we'll start with the normocytic anemias. Hope the video is helpful. Thank you.